Hello, dear. It's all good to be back, and I hope that you had a wonderful weekend and a great Monday as well. And I'm very happy to be back once again with, five upcoming events starting from today. As you know, we are here every single day to support you, to answer some of your questions. And of course, we have lots and lots of interesting topics. And again, we have a very special guest with us tonight, and this is Laura Vanos, and she's the embryologist at IVF-Spain. And so thank you so much for joining us once again. This is your second webinar with us, so thank you so much for joining us once more, and of
You're
course
welcome.
giving us this other topic as well. And how are you feeling tonight, Laura? Hope all is okay.
Fine, thank you.
Thank you
Thank you,
so much.
Karen.
Thank you so much. And of course, just to let you know, of course, we will start with Laura's presentation on our topic, which is sperm preparation. And afterwards, as always, it will be time for your questions. All you need to do is just type those in the chat section, and Laura will answer them for you right after the presentation. And just to let you know, there are over 300 IVF webinars now on myivfanswers.com, and I just want to mention that My IVF Answers is a part of European Fertility Society, which is here to simply bring you some knowledge, give you some opportunities to meet top fertility experts, and also ask your own questions from those and find out a little bit more on various topics. As you know, last week we started with male fertility topics, and we are continuing this week with this particular topic. And yeah, that will be it from me at this point. Laura, are you ready to start with your presentation then?
Yes,
Happy to hear that then.
thank you,
And
Karen.
let's go ahead then.
Okay, perfect. So thank you very much, everyone, for being here. Good night. The topic of the presentation of today, as you know, is sperm preparation. So we're going to speak a little bit about male fertility today, the causes that can lead to male infertility or subfertility, and how we approach this in fertility clinics when patients come to have a treatment. So the contribution of the male factor to fertility, of course, is huge. 48.5 million couples are said to be infertile worldwide. Male factor accounts for around 30% of infertility cases nowadays. This is if we only consider cases where there is only a male factor involved, but very often there is both female and male factor involved. So if we would consider also these cases, the percentage would go up to 50%. So we're going to present this slide with a summary of the main causes that can lead to male infertility or subfertility. We have blocked them in three groups, depending on the source of the problem. Pretesticular conditions would be those where there is a hormonal problem. So this means that the actual sperm factory is working properly or would be able to work properly, the testicles, but the signals that should start the process, the signals that should arrive from the brain to start producing sperm cells are the ones which are missing. So within this group, we would have hypogonadotropic hypogonadism. This means that the areas of the brain responsible for producing these hormones, like the hypothalamus, the hypophysis, pituitary gland, are not producing the hormones, GnRH, FSH, LH. So since they fail to produce these hormones, the testicles are not receiving the proper signal, and this is why the whole system is shut down. Hyperprolactinemia would be a particular event where the high levels of a hormone called prolactin have an inhibitory effect on these glands in the brain. And so, again, the whole system eventually shut down because of this hormonal inhibition. There are also some medicines which can produce the same effect as prolactin, and some substances, like, for example, anabolic steroids, and which can also shut down the whole sperm production machinery. The second list of conditions would be the testicular ones. So these are the ones that really affect the sperm factory, so to say. Within this group, we would find varicocele. This is a really common prevalent condition in the population, the male population. Varicocele means that the veins in the testicles are enlarged, and for this reason, the blood pools in the testicles. The temperature rise, this is bad for the testicles, and the sperm counts go down and testosterone levels go down. Cryptorchidism would be another condition which is quite prevalent in the population. This refers to undescended testicles after birth. If this tends to resolve itself on its own or with a little surgery, but if both testicles do not descend to the sac, this might provoke later problems of fertility during adulthood. Of course, in this group, we would find also testicular cancer, and the treatment for this cancer, chemo or radiotherapy. The disease and also the treatment can impair sperm production. So it is very important we remind to freeze sperm before such a treatment, even though physicians sometimes forget about the fertility issues. If you had a physical trauma in your testicles or you had a surgery in your testicles, this can make the tissue change and this can also impair sperm production. There are also some genetical conditions which can prevent normal sperm production. For example, Klinefelter syndrome would be such a case. Klinefelter male are male who have an extra X chromosome. So they have a XXY karyotype. And these men physically are completely normal, they are healthy, but they are not producing sperm in a normal way. And there can also be Y chromosome microdeletions, in particular in the regions AZF, which can lead to no sperm production or little sperm production. And some rarer syndromes, less frequently occurring, like primary ciliary dyskinesia, including Carter-Jenner syndrome, or Sertoli cell syndrome. Also, infections could lead to no sperm production or lower sperm production. And some environmental factors can also impair sperm production. For example, exposure to heat. The testicles have a lower temperature than the rest of the body. So if you would expose them to a source of heat continuously, this would also lead to impaired sperm production. There are also some autoimmune diseases which can lead to the sperm producing antibodies which will attack your own sperm cells. So this would also be a fertility problem. And so then we would go to the third list of diseases or conditions. These are conditions where the testicles are producing sperm in a normal way. The signaling is working all right, but the body fails to expel the sperm cells to the exterior and thus to lead to a viable pregnancy in a natural way. The sperm cells, like we said, are produced in the testicles. They later mature in an organ called the epididymis. And on their journey to the outside, they will travel through a duct and pass by some glands, which will contribute to the ejaculate final volume and composition. So there might be some medicines that impair normal sexual function. Another condition within this group would be retrograde ejaculation, where part of the sperm ends up in the bladder, so it is lost. There are also some genetical conditions like Young syndrome or congenital bilateral absence of vas deferens. This is associated to some mutations of cystic fibrosis, but it does not mean that you need to have the disease to have this absence of the ducts. So there might be healthy people who do not know that they do not have these ducts. There might be obstructions of the ducts. Of course, people who underwent a vasectomy will not be able to have sperm cells in their ejaculate. There are some nerve injuries or spinal cord injuries, which could also prevent normal sexual function. And of course, systemic diseases, which could also prevent this. So when a couple arrives at an IVF clinic and they've been trying to have a baby for more than a year and unsuccessfully, the first thing that we will do in a fertility clinic to assess the male fertility, the first thing that will be done in any fertility clinic is to perform a basic sperm analysis. So in a basic sperm analysis, we'll look at the sperm count, sperm motility, sperm morphology, and also pH, white blood cells, volume, and color. pH and volume can be important for us to know if there might be an obstruction problem, so a problem from the third category of conditions that we just listed. If the volume is low and the pH is acidic, we might have a suspicion that there might be an absence of vas deferens, for example, because this is usually associated to a dysfunction of the seminal vesicle, which produces alkaline basic components of the sperm. So this is why the sperm would have an acidic pH. For example, white blood cells, if we see that there is a high quantity of white blood cells, more than 1 million per milliliter, we might have a suspicion that there is an infection going on. So this could give us a hint of something that is going on. And also if we see some blood in the sperm sample, if it has a reddish color, this could give us a hint of something going on. But to assess the fertility itself, we will mainly look at the sperm count, the sperm motility, and the sperm morphology. According to the World Health Organization, the normal standards would be to have more than 15 million per milliliters in a sperm sample, or a total of more than 39 million sperm cells. If we have less than this, it would be considered oligozoospermia. Progressive motility, so the percentage of sperm cells which are able to move from one point to another, should be above 32%. And this would be, if the values are lower than this, it would be considered as tenozoospermia. And for morphology, we're happy with as little as 4% of normal shaped cells in the sample. Less than this would be considered teratozoospermia. So these are the threshold values that the World Health Organization set in their last manual. There's a new one about to come out, but this is the one we're currently using. If you have values which are close to these, but not very far away, this might not mean that you have a big condition like the ones we just previously mentioned. Perhaps you just have bad lifestyle habits, you're smoking too much, drinking too much. Perhaps you could do with losing some pounds, or in turn you should gain some pounds. Perhaps you're exercising too much, or taking some substances which are affecting your sperm quality. Perhaps you just have a fever. So it might not mean there is a big condition going on. This might just be a natural deviation from normality, and in fact that you also have completely healthy lifestyle habits. It could also be because you have a high age. Sperm quality also decreases with age. So it should not necessarily be something you need to worry about, although of course general checkup in your GP can never do any wrong. It is when we have extremer cases, so for example, when we have a concentration of less than 5 million per milliliter or something like this, where we might order some hormonal analysis. So especially we would check the testosterone levels, as well as FSH and prolactin and so on, and perhaps recommend the patient to have a physical exam done by a neurologist. It also does not mean if you have some lower values than these thresholds, it does not mean that you cannot naturally become pregnant. Perhaps you could, but probably it will just be a little bit more difficult, or it might be a reason why it's taking more time. So we've spoken about the basic sperm analysis. If we have a normal sperm analysis in an IVF clinic and a patient is going through a cycle, or if we have an almost normal sample, the techniques that we will use as a routine are density gradients, swim-up technique, and selection of sperm cells under the microscope. In density gradients, what we will do is we will place the raw sample on top of 2 or 3 layers of media with different densities, and we will place a tube and the centrifuge. And during the centrifugation, what will happen is that the sperm cells will separate from the other components of the sperm. So we will retain only the sperm cells. We will wash them through another centrifugation. And then afterwards, the pellet, we will put some clean media on top. And what will happen is that the sperm cells which are able to move, the fastest ones and the strongest ones, will swim up through the tube. So we will wait a little bit, and what we will do is take an aliquot from the upper part of the tube, because we know that here are the fastest and the strongest sperm cells. So with this already previous selection, if we're going to perform ICSI, we will place it under the microscope, and with an amplification of 400 times, we will select the best looking sperm cells for fertilization. If we're going to fertilize through IVF, then we will just adjust the concentration of the aliquot. So up to here, basic sperm analysis, basic preparation of sperm. But of course, we know there are more things going on with sperm. For example, we know that with advanced paternal age, the rate of miscarriages increases, the rate of fertilization decreases, the quality of the embryos decreases. So we know that there is something more going on with sperm than what we can see with our bare eye. So for this, we have included molecular tests in our routine analysis as part of an advanced sperm analysis. And basically, what we test for is sperm DNA fragmentation and apoptosis. Sperm DNA fragmentation refers to the breaks that the genetic code of the sperm has. It is normal to a certain extent, unejaculated samples, the sperm in them will have a little bit of fragmentation. This is normal, and the egg can repair to a certain extent. But if this fragmentation is really, really high, it will affect embryo development, and it will affect the prognosis of the patients. So you do not want to fertilize the eggs with really fragmented sperm. So we test this through a sperm chromatin structure assay currently at our clinic through flow cytometry. If we get a DNA fragmentation index of less than 15%, we would consider the DNA fragmentation to be normal. If it's between 15 and 30%, we would consider it to be pre-pathological, and above 30%, it would be pathological. Next, apoptosis, the second molecular factor that we check. We also check this through flow cytometry. And apoptosis means literally programmed cell death. This means that there are sperm cells that are moving freely. They look completely alive, but in fact, they have started the process of dying. So again, you do not want to fertilize your egg with a dying sperm cell. To a certain extent, it is normal to have some apoptotic cells, and probably during basic preparation, you will remove some of them, but for some patients, this is increased. We consider that it is increased when we have a result of more than 30% of apoptosis. These are markers that are also sometimes increased with paternal age. So there might be older men having higher sperm DNA fragmentation, and sometimes it's also increased in people with previous failed cycles. So there are specific techniques that we can use to address these particular problems for people who have high DNA fragmentation or high apoptosis. So, like we were mentioning, we have the usual techniques, density gradient swim-up, watching, and we have some additional techniques, which would include using alternative sources for sperm, MAX technique, PICC technique, sperm cell technique, IMSI, calcium ionophore media, sperm expression for diagnosis, and microfluidics. So regarding the alternative sources for sperm, obviously the main source for sperm is ejaculate, which we will use in the majority of cases. But for some people, it might be necessary or preferable to use alternative sources. These alternative sources include testicles and the epididymis. We can extract the sperm cells from the testicles or the epididymis through aspiration with a little needle, or we can do it with a little surgery. The sperm cells are produced in the testicles and later mature in the epididymis in a process that lasts like 2 months, 2.5 months. This might be necessary taking the sperm from here in cases where patients underwent a vasectomy, of course, in patients who have big difficulties to collect samples. in cases of patients who have absence of vas deferens. So basically everybody in the third group that we were mentioning before. And there are also some patients who seem to have a better quality of sperm in the testicle, so with less DNA fragmentation, with better prognosis than they have in the ejaculate. So it seems like for some patients, during storage or during maturation, the sperm gets damaged. I forgot to say that also for these alternative sources, the sperm cells, the sample that you're handling for ICSI looks different than when you're handling an ejaculate. And you need to have a little bit of experience to perform such an ICSI. Sometimes, as part of the sperm preparation, we need to use some extra stimulants to be able to discern which of the cells are the most lively ones, the best moving ones, and we use theophylline and pentoxifylline for this use. So the next technique we'll speak about is MAX technique. MAX stands for magnetic activated cell sorting, and this technique is used to select sperm cells with no apoptosis. So the technique is based on the fact that apoptotic sperm cells, so sperm cells which are dying, the second test that I just mentioned, they have a lipid in their membranes that is called phosphatidylserine. This lipid happens to bind to a molecule which is called annexin 5. So in MAX technique, we have a column which is coated with microbeads with annexin 5. So when you pass the sperm cell through the column, the apoptotic sperm cells will bind to it, and you will obtain a subset of sperm cells which are not apoptotic. So it's a way of selecting sperm cells which show no apoptosis for people who have this increased. The next techniques we'll speak about are PIXI and sperm slow. These are basically based on the same principle. When we do the SCSA test, not only do we learn about the DNA fragmentation index, but we can also see if there is a higher proportion of immature cell. This also tells us something about the integrity of the sperm cell. This is a very easy to use technique, very fast. PIXI dishes are dishes coated with hyaluronic acid. And this is based on the principle that mature sperm cells will express receptors for hyaluronic acid. So when you put a droplet of sperm in the dish, the mature sperm cells will be binding to the hyaluronic acid. So they will have a very characteristic movement where the head is stuck but trying to move, whereas some sperm cells will be moving around completely freely. You do not want to take the sperm cells which are moving freely because these are the ones which are immature. The same happens with sperm slow. Sperm slow is a media rich in hyaluronic acid. So you will put a droplet of sperm slow, a droplet of sperm suspension, join them, and in the intersection, look for these sperm cells who seem to be stuck to the hyaluronic acid. Next, how do we select for DNA fragmentation? In the latest years, we have seen the rise of the use of microfluidics. These are systems that allows us to select sperm cells which have no DNA fragmentation from the raw sample. They have pairs of microwells which are connected with microchannels, and the sperm cells with no DNA fragmentation, which have a characteristic movement, will be able to migrate through these microchannels. So you place the raw sample on one end, and you collect, after some time of culture, the sample that arrived at the other end of the channel. And this is the one that you will use for fertilization. So in the picture, we can see two images, two kinds of tips. In one, we will use a high volume. So we'll use 850 microliters, and we will retrieve around 500 microliters. This allows us to retrieve quite a high volume when we process a sperm sample. And so we will be able to use it for an intrauterine insemination, as well as for any ICSI or IVF procedure. With the other one, we're using a very little volume, and we also retrieve a really little volume. So we will only be able to use it with ICSI. The good thing about this is that it allows us to select for DNA fragmentation, and also that it avoids centrifugation, which is supposed to be a source of Ross species and perhaps also induce DNA fragmentation. And the setbacks would be that perhaps it's not the best system for samples with very low concentration or severe sperm samples, and perhaps also not for frozen sperm samples. So the next technique that we're showing here is IMSI technique. This allows us to select sperm cells according to their morphology. So you would start preparing the sample as a regular ICSI, but basically you will place it under a microscope that has a bigger amplification. Whereas in a normal ICSI procedure, you have a 400 times amplification. During IMSI, you have 6,000 times amplification. So you can see the sperm cells better, and you can see if they have back walls or not. You can select a little bit better according on how the sperm cells look like. The setback of this technique would be that it takes more time to perform the ICSI, so it could be a little bit more aggressive, so to say. And also that if, as an embryologist, you're not used to collecting the sperm with such a big amplification, it might also make you lose some dexterity. So next, we have included this slide about another problem that is related to the genetic code of the sperm cells. This is DNA compaction. So DNA, the genetic code of the sperms, is compacted inside of the cells thanks to two proteins, protamine 1 and protamine 2. In fertile men, these proteins have a ratio of 1:1. This means we have the same quantity of protamine 1 and protamine 2, but in subfertile men, it has been seen that many times this ratio is altered. So it might be that the histone to protamine transition is not working correctly, and this could explain some cases of previous fertilization problems, previous failure of IVF cycles. So this KIT sperm expression tool allows you to find out if you are expressing a different ratio of these proteins. It's a very easy to use kit, which they send home to you, and you can obtain a fast result. We have included also one slide about a technique of artificial oocyte activation. This artificial oocyte activation is indicated for patients who have had recurrent fertilization failure. So this means that less than 1/3 of their mature eggs fertilized in previous IVF cycles. When a sperm is introduced in an egg, or when a sperm naturally fertilizes an egg, this triggers calcium oscillation, calcium ion oscillations, and this triggers a molecular pathway that eventually will lead to fertilization. So some fertilization failures, although not all, may be due to the lack of this activation of calcium waves. So this failure to activate may be both due to X factors or sperm factors. In particular, it has been linked to globospermia, which is a particular morphological composition problem of the sperm. There are many ways to provoke this artificial oocyte activation in the laboratory, but the most common one, and the one that we're using in our laboratory, is calcium ionophore. This is a very easy to use protocol. What you have to do is to culture your embryos in droplets of calcium ionophore rich media for around 10-15 minutes right after ICSI. And what we do is we do this with 100% of eggs in case of previous complete fertilization failure. So if patients come to us and previously none of their eggs fertilized, we will use calcium ionophore culture for all of their eggs. However, we'll only use it in 50% of eggs in cases where only around less than 1/3 of the eggs were fertilized, and see if it's really helping. So we also wanted to include some slides about sperm freezing, because sperm freezing is becoming a very usual technique in IVF clinics, and more we're working a lot with frozen sperm samples, especially in this context of COVID. We're working a lot with frozen sperm. So for this reason, in the past years, we have put a lot of effort in improving our sperm freezing protocols to try to obtain the best results. In the same way that it happened with eggs and embryos, there was a transition where initially we were using a slow freezing technique with eggs and embryos. And slowly this was completely modified in Europe by vitrification, which is ultra-rapid freezing. Although most clinics are still slow freezing sperm, we have been improving in the past years our protocol of ultra freezing of sperm to avoid glass formation. And currently we have been successfully using this for around 2 years with really good results. So in fact, when we see a good quality after thawing the samples, afterwards we have the same results as with fresh sperm in terms of blastocyst rate and pregnancy rate. We have included this image of microscopy pictures of sperm that my colleague took at the university of fresh sperm cells and of sperm cells that were thawed after slow freezing and sperm cells that were thawed after vitrification. Like my colleague could see, the sperm cells that were thawed after vitrification looked less damaged and less affected than the ones which were thawed after slow freezing. So we thought it was a great achievement and a great success, and we're very proud about it. And we think this might be the future in cryopreservation of sperm samples. So this is the end of the presentation. It's a little summary of the techniques that are being used right now in IVF laboratories for sperm preparation. Perhaps you have heard of some more. Thank you very much for your attention. I will be happy to hear your questions about all of this. And of course, if you have some further questions, feel free to contact our medical team to the following email. Thank you very much.
Thank you so much indeed, of course. And that was definitely an interesting presentation. Lots of details. So as you can see, we have some questions already in regards to some of the techniques you actually mentioned in your presentation. So yeah, let's get to the questions, of course. Yes, let's have a look at the very first question that we got here. So my husband's sperm count showed actinozoospermia, and which additional technique would you recommend for ICSI?
Well, in principle, if your husband has actinozoospermia, a regular, if the concentration of the sperm is normal, regular processing of the sperm sample, if it's not something extreme with density gradients and swim up, should improve a lot. Just doing the swim up should improve a lot the motility of the aliquot that we would use. And also using ICSI could yield a lot of better results. If you have not performed an advanced test, perhaps I would recommend to do so, so that we can rule out that there is something more going out molecularly, like high DNA fragmentation or high apoptosis. But if this is the only thing that is going out, a normal sperm preparation with ICSI technique should do to improve the results.
Excellent. Thank you so much for your very first question and your answer to that. And actually, we do have some more questions from Bubble. So let me just go straight to, sorry, the next one is not from Bubble. Melissa has added, is the fertile chip or max technique better?
Well, it's not that one or the other are better, but that they are indicated for different things. So fertile chip would be the technique I would recommend if you were diagnosed with high DNA fragmentation. And max would be the technique that I would recommend to you if you have high apoptosis. So perhaps I think in the routine clinic, fertile chip is used a little bit more because it's perhaps really easy to use. So there are actually laboratories that use this to process most sperm samples. But I wouldn't say that one is better than the other, just that they are recommended for different cases.
All right, of course, understood. Thank you so much for that. And let's have a look, of course, at the question we got from Babel again. So does it make sense to use max when a sperm count shows less than 4% normal form?
Yes, if I would say if you have a sample not with low form of normal forms, but with a really low concentration, then perhaps it would not make so much sense to do a max technique where you cannot make a big selection. But yes, it could make sense to use max for normal forms, not because the normal forms itself will be solved by the max technique, which is not the case. But perhaps the fact that you have teratospermia might be an indication that also molecularly the sperm is not doing so well. So you might want to extra select sperm which have a good molecular integrity, and max could help for this. But it's not really like max is indicated for teratospermia. What I would recommend is to do an advanced sperm analysis. And if everything comes out okay, depending on your previous history, if you have no worrisome previous history, then perhaps it would not be necessary. It would not really be an indication. But if there are other indications in your previous history which might make us have a suspicion that there is something more going on, and the molecular test that you perform show that something strange is going on, then perhaps it could be an indication for you.
All right, again, thank you so much for that again. And let's have a look. Of course, more questions are coming in. And now we have another question. Do you perform FISH analysis to check for aneuploidy in sperm cells?
Yeah, that's a good question. Yeah, there are some patients who request this test, and we perform it. Eventually, if the result of the FISH test is that you have a little bit higher percentage than you would expect of abnormal chromosomal content in the sperm cells, what you would do is perform PGS. So already in many of our patients, we will be directly recommending this because of high advanced female age, because of the previous history of the patients. So when we're going to do PGS anyway, we do not perform FISH analysis because eventually an altered result of FISH anyway would lead to PGS. But yeah, we do perform this for some specific cases.
Okay, again, thank you so much for that advice, of course. Let's have a look, and next question is up. We have poor sperm and NK cells. I am 35 and wondering if IVF is our only option. If yes, what chances do we have?
Well, only option it will rarely be. No, you can keep trying, and perhaps someday you will be lucky. But the problem is, from out 35 years old, your fertility decreases. So you should definitely get checked and see what are your hormonal values, what is your ovarian reserve. If you have already been trying for more than a year, relatively not common mistake, but sometimes people go to their gynecologist and they say, yeah, just keep trying, and they do not get tested. And when they get tested, they realize it's too late because, you know, they do not have enough ovarian reserve anymore. And now the picture is a lot more complicated and everything gets more difficult. So if you can perform some tests to see how much time you have, but be aware that from out 35 years old, your fertility will decrease, and the quality of the eggs and the euploidy rate of the embryos will also decrease. So depending on the results and for how long you have been trying, yeah, I would definitely go to a physician, have a fertility check, and follow the doctor's recommendations. So you do have a chance, but you should go and see a doctor.
All right. Again, thank you also for that advice. Yeah, so it's important not to waste time. That's for sure. Thank you so much, of course. All right, let's have a look. Nina has added one more question, but of course, if that might be our final question. However, I do want to make sure that you have asked all of those questions. So go ahead and type those in. And the question is here. What would you suggest for our combination endometriosis, adenomyosis, and morphological problems?
So in this case, you might expect that there is both a female factor involved and a male factor involved, which can make it a little bit more complicated. So the fertility specialist will be the one handling the female part, doing the best part to try to improve the egg quality, to try to have the best stimulation possible, to try to obtain the best eggs possible, which will have a major role, of course, in the cycle. And the morphology problem we will solve in the laboratory, or we will try to improve in the laboratory. Perhaps this would complicate your chances of having a natural pregnancy, but in the laboratory, actually, it's quite easy to solve, in the sense that we will prepare the sample, because we will have millions of sperm cells, and out of these millions of sperm cells, we will only take the best ones eventually. So unless it's a very extreme factor for us in the laboratory, it's not such a difficult point. It can sometimes diminish a little bit the blastocyst rate, so how many embryos you get from a cycle, but it is something that we can quite easily sort in the laboratory because of this big selection of the sperm cells.
Excellent. Thank you so much. Yeah, it's once again, of course. Okay, next. Actually, not a question, but it's a comment. I definitely want you to see that. Thanks very much for a great talk. It is very nice to hear from the people doing the hands-on work in the lab. Thank you so
Thank you
much.
so much.
Yeah, definitely. We are very
Bye-bye.
happy to be able to have not only doctors, but also, embryologists, anyone that actually is like you, Laura, right? So thank you so much for that comment as well. And Melissa has added, what about Pixie? When is it recommended?
So the thing about Pixie is that it's such an easy technique to use, and also not time consuming in the laboratory, that we might use it also when we have just a suspicion that something might be going on, because in any case it will do no harm. So really the super indication for Pixie would be when we perform a SCSA test, and we see that there is a big population of immature cells, which we have seen sometimes. This would be the super indication for Pixie. But perhaps also if there is a slight DNA fragmentation, which is high, or some suspicion that there is something going on with the sperm, because anyway, it will do no harm. So a little bit for sperm factors or suspicion of sperm factors, we could perform Pixie.
Okay, thank you once again for that question, Melissa, and of course for your help, Laura. And actually, next one is definitely interesting question, that's for sure.
Okay.
Let's have a look, okay? Thank you for your presentation. I am currently finishing my master's in biochemistry and would like to become an embryologist. As an embryologist yourself, what do you recommend next? My next steps would be.
So right now out in the market, there are a lot of specific master degrees to become an embryologist. So in Spain, there are a lot of master degrees to become an embryologist. I think in the UK also there are some master degrees to become an embryologist. And I would recommend to pick the master which offers you the biggest chance to do internships, because the theory you can learn easily, and anyway you will learn during your work. But the training that gives you some hands-on training, and which allows you to make contacts in the IVF world and to put a feet already in a working place, this would definitely be the best master degree.
That's great to hear, and we are happy to have one of the future embryologists, I guess, as well, right? So, thank
Yes.
you for joining. It's good to know that you are out there and interested in that field. So, thank you so much for that.
Thank you,
And
Cassandra.
well, let me have a look. I do not see any more questions, so we will be slowly finishing. But of course, as already Laura has mentioned at the end of her presentation, if there are any questions that you haven't asked today, or you would like to simply get in touch with the IVF Spain team, just go ahead and get in touch with them. I'm sure they will be more than happy to help you out. And I'm just waiting to see if there is anything else. If not, we will be finishing. And so before we finish. Laura, anything else you would like to add?
No, just usually people are really worried about what they can do to improve their sperm quality. And actually, this is really quite logical things like just having general healthy lifestyle habits and not abusing anything, not abusing sport, not abusing substances, not abusing alcohol. And really, sperm problems in the laboratory are usually quite easy to solve. So, yeah, let's say that the egg problems are a little bit more delicate, and the sperm factors definitely contribute to pregnancy being difficult to achieve naturally. But in the laboratory, they are quite easy to solve.
That is really good to hear as well, of course. So thank you for finishing this with on that very positive note, for sure. Thank you so much for that. And as you can see, there is one more thank you for you in regards to your presentation and of course for all the sessions. So thank you everyone for joining us tonight, for your great questions, and I do believe it's been very useful to you, Laura. Again, thank you so much for joining, for your sharing your knowledge as well, and of
Thanks to
course,
you.
I do hope that we will simply be able to have another webinar with you. It's getting more and more easy, right? As you have mentioned.
Yes,
Exactly.
definitely.
So, thank you so much. And of course, remember that we will be back here tomorrow at 8 p.m. UK time. So, I hope you will be able to join us. And of course, this webinar, you will be able to find it on my IVF Answers YouTube channel. And if you go to our website, you already know that there are over 300 webinars there with lots and lots of topics. So, I do hope to see you here tomorrow. And Laura, till our next time, then, okay?
Bye,
Thank you so
Carolyn. Thank
much.
you so much.
Take care, everyone. Have a lovely evening. Bye.
Bye.